All right, the recording is started. We'll do one thing. Good afternoon. We'll start off the session, ma'am. Welcome all delegates for this webinar that we have scheduled. This is being done on behalf of the Residence Committee of KCIAPM. Dr. Nitishri is joining us as head of the Residence Committee, and Dr. Kanashri from the Residence Committee will be moderating the session. We have some audio issues with them. We'll be fixing that soon, but we'll get started with the webinar that we have scheduled. This is basically the third webinar of the series, which has been initiated by the residents, for the residents. And first was by Dr. Suresh Nagwadi, and second was by Dr. Archana Bhatt. And this is the third session that we are organizing. This webinar is basically on the cytology circuits from pap smear to HPV testing. And we have two very prominent resource persons for this particular session. First being Dr. Julian Crasta, Professor of Pathology at St. John's Medical College, Bangalore. And she'll be followed by Dr. Reshma Kini, Professor of Pathology at Father Muller Medical College, Mangalore. So I welcome you all, ma'am, to the session. And without wasting much time, Ganeshri, are you audible? No, no, not yet. All right. You're not audible yet. No problem. Julian, ma'am, I welcome you on board, and I request you all to begin your talk.
Thank you. Thank you very much, Dr. Aditya.
Click on share screen and select entire screen. Tap on the screen and click on share button. Ma'am, I think please stop sharing. This is click on share screen and then select entire screen, ma'am.
1 minute. Okay.
Entire screen option. Entire screen.
Okay.
And then tap on the screen and click on share button. Yes. Yes, it's seen, ma'am, now. You open your PowerPoint and you go ahead and share. Yes. Yeah. Slideshow mode, ma'am. Okay. It's perfect, ma'am.
See now?
Yes, ma'am. It's loading up.
Yeah.
Just a second.
Okay. Can you see that?
Yes, ma'am. Go ahead, ma'am. Thank you.
Okay. Thank you. Thank you. Good afternoon or good morning, everybody. Today we will go through the cytology as a cervical screening tool. I'll be talking mostly on the conventional and a little bit on the advances which has taken place in cervical cancer screening. I've named it as a foundation of cervical screening because conventional pap smear is where it all started with the control of cervical cancer. So it all started with George Papanicolaou exploring the utility of exfoliative cytology to study the cells of the lower genital tract of the females. He collected the collections from the fornix, made a slide into it, and tried to study the cellular details. Now, this in the early 20th century became a screening tool for screening cervical cancer, which was cytology based. This has been the most successful public health screening program amongst all the programs which have been available, which decreased the mortality and morbidity of cervical cancer. So cervical cancer worldwide, which was the most common cancer in females, have been reduced to fourth because of the efforts which have gone into screening programs. In India, we don't have an organized screening program, and it has always been opportunistic. That is, when a lady comes into the hospital for some other problem or any other gynec problem, we take a pap smear and try to give her the benefit of the screening which the benefit offers. However, cervical cytology is not a very 100% efficient. Its accuracy is only moderate. Partly because of the biology of the disease we are looking into, partly because of the technical glitches. So it requires repeats at regular intervals. So pathology lab will be always looking at a workload in cervical cytology. So just to have a thing in the what WHO is taking, how WHO is looking at the cervical cancer burden is that they've started a cervical cancer elimination initiative, which goes as 90, 70, and 90%, where the aim by 2030, 90% of the girls should be vaccinated with HPV vaccine by the age of 15. 70% of the women between 35 and 45 years should be screened, and of the screened people, women who have an abnormality, at least 90% should be treated. If this is achieved, the WHO forecasts that the incidence of cervical cancer will be less than 4 per lakh women years by 2030. However, the scene is bleak in India because only 2% of the women aged between 29 to 40 years undergo regular screening program in India, and only 29.8% in India have a once in lifetime screening opportunity, as opposed to US where only 30% are not screened and 70% are screened. So coming to the conventional cytology as such, all of you know that a speculum is inserted, collection device is inserted into the os and moved 360 degree to obtain a sample both from the ectocervix and the endocervix. Even sampling devices have evolved. Now we use a cytobrush, which the tip of the brush will go into the endocervix and the rest of the brush will collect from the ectocervix, which is smeared onto the slide and stained with Papanicolaou stain. So a stain, conventional smear will look like this because it is smeared. You have mostly clusters of the cells, sheets of cells, and some individual cells. Now I will not dwell deep into Bethesda TBS 2014, but according to 2014 Bethesda system, for a specimen to be adequate, we need to have adequate clinical information. The smear should be of good quality with good fixation and good staining. Squamous cell cellularity and the transformation zone should be sampled, and the obscuring element should be less than 75%. How do we, the two things which you have to keep in mind is a adequately fixed and stained smear with a adequate amount of squamous cellularity. For a conventional smear, the TBS says you should have 8,000 to 12,000 cells, and any sample with abnormal cells, though there is a paucity of squamous cellularity, becomes adequate and it should be easily visualized. Now we need not calculate the cells, sit and count the cells. There are some reference
Okay.
images which I will show you. Now, transformation zone is not a criteria. Absence of transformation zone is not a criteria to reject a, smear or to label it as unsatisfactory. Just to give a feedback to the clinician on his collecting efficiency, we give a note on transformation zone. How is it defined? At least 10 endocervical cells or squamous metaplastic cells in singles or in clusters should be present to say that the transformation zone is sampled. Now, these are the references images. In a low power field, that is 4x, if you find 75 cells, it is approximated that estimated that there are 75 cells in this image, and this kind of cellularity should be present in the entire slide. If you have something like that, it is estimated that 500 cells are present, and you need to have at least 16 fields with this kind of cellularity. If this cellularity is like this, it is estimated there are 1,000 cells and you need to have 8 to 12 fields to say squamous adequate number of squamous cells are present. Now, if you have this kind, it is estimated it's about 1,500 cells and you need 6 fields like this. So it is just a rough estimate by eyeballing the entire slide and saying whether adequate squamous cells are present or not. Now, what are the normal cells which are present? We have mature squamous cells, which are intermediate, and the superficial cells. Intermediate cells are usually cyanophilic cytoplasm. These cells are large, have a large amount of cytoplasm, which is cyanophilic, and a nucleus which is a little with a little open chromatin, as opposed to superficial cell, which is fully keratinized, so it takes orangey and it becomes orange or pinkish eosinophilic orangeophilic cells will be seen, and the nucleus is pycnotic. Now, conventional pap smear collection is by drawing the smear on the slide. So it depends so much on weather conditions, whether, and it can give a lot of drying artifact. So sometimes you might end up finding a eosinophilic cytoplasm in an intermediate cell also because of the drying artifact. So we depend on the nuclear characteristics to divide whether to identify them as superficial or intermediate cells more than the cytoplasmic characteristics. Now, the basal and parabasal cells are smaller as compared to the intermediate cell. So their nucleus appears big. They do have a vesicular chromatin, and the basal cells are further smaller, and they might look like that they have an increased nucleocytoplasmic ratio. So because of this morphology, the parabasal cells enter into a differential diagnosis of various high-grade squamous intraepithelial lesion. So you have to be very careful when you see a postmenopausal atrophic smear. Now, the other cells which are present is if the transformation zone is sampled, you will have the endocervical cells. When they are fall end on the slide, you have honeycomb appearance where the cells are closely packed together. Cell margins, cytoplasmic margins can be made out. However, the chromatin is very clear and the nuclear membrane is very regular. If the longitudinal strip of endocervical cells appear, they will have a what we call as picket fence, where the nuclei are towards to one end of the longitudinal cell, that is the columnar cell, and the cytoplasm is to the other side. So they appear to be sitting next to each other, which is called as picket fence. Next comes the metaplastic cells. The endocervical transformation zone, there can be a squamous metaplasia. When you pull out these cells, no, the cellular junction gets spread out like this. So they look like a spidery cells, and they look more like a parabasal cells. However, the cytoplasmic characteristics and these spinous processes you should be able to make out between metaplastic squamous cells. Sometimes it's really difficult. The next cells which can come is the endometrial cells, which is called as, when you get these clusters, it's called as exodus, where you have the columnar cells bordering a clump of stromal cells. They will be dark stained like this only. It's very difficult to capture on the picture. You will have small stromal cells surrounded by these columnar cells. These are very normal to find in the first estrogenic phase after the menstrual cycle. After the menstruation, it is first 15 days, it's normal to find in females with reproductive age group. So therefore, Bethesda says report this only in females more than 45 years. Initially in 2004, they said 40 years, but when there is studies have done, it increases the number of referrals for further biopsy, and it didn't seem to be cost effective. Therefore, now they have made it 45 years. You will report them, when you see them, you will report them only in a woman who is more than 45 years of age. Now, the components of the Bethesda system, all of you know, we will not go into details of this. I have addressed the adequacy criteria. Let's straight go into negative for intraepithelial lesions, in that also a few infections. Now, what we are seeing here is the pap smear with the square in superficial cells and intermediate cells, and in between you are seeing this small ovoid or polygonal structure which has a very hazy nucleus. Okay, these are the tropozoites of Trichomonas vaginalis, and because of the inflammation, the cells are showing reactive changes with this regular perinuclear halo, which shouldn't be confused as collocyte. And one more clue, where you can be very sure these are tropozoites, is by their nature to stick to these mature cells. The cell here is obscured because the number of tropozoites which are sticking to the cell. Can you make out this reactive halo? Sometimes when you can't see, this reactive halo should tell you that you should look out for some infection, especially Trichomonas vaginalis. Next common infection is the candidiasis, where you are seeing this, you can see it as pseudohyphae. It's called pseudohyphae because the budding spores sit next to each other and form a long structure which looks like hyphae. It's not true hyphae, and sometimes you can have this. Most of the times we see spores like this and in association with this pseudohyphae. Now, the main aim of the screening here, cervical cancer screening, is to detect pre-invasive and early invasive carcinomas which have not grown enough to be visualized at the perspeculum examination. So we are trying to detect this pre-invasive looking at the abnormality seen in the cell. So how do we identify a abnormal cell or abnormal cell clusters? So these are the points you need to remember, minimum number of points which you remember and evaluate when you are looking for a neoplastic cell. The architectural pattern of the cells, though it's not histology where architectural pattern is well appreciated, cytology also mimics the original pattern. So the pattern gives a clue. Then the main is the nuclear features. Look out for the nucleocytoplasmic ratio, pleomorphism, the chromatin pattern, whether it is uniform, vesicular, clumped, coarsely granular, or finely granular, irregularity of the nuclear membrane, presence and absence of the nucleoli. We'll come to the nucleoli, certain non-neoplastic conditions it can appear. Then the quality of the cytoplasm, whether the cytoplasm is keratinized, whether it's opaque, dense, or vacuolated. Coming to the squamous lesions, all of you know this is a squamous cell carcinoma. So if I take a pap smear from this type of thing, what will I see? I will see either neoplastic cells, abnormal cells as isolated cells, or small clusters. And these cells are smaller, much smaller than the mature intermediate or squamous cells, and there the cell looks like it is filled with the nucleus only. So it becomes increased NC ratio. There is a hyperchromatic nucleus, and the cells are more scattered rather than sitting in clusters. I got a bigger cluster here, which brings out the features very well. That is, there is a anisonucleosis and a granular chromatin. If you go closer, it is granular. When you see under microscope, here it looks more distinct, more hyperchromatic, and a small nucleoli here, which is coming up under dense eosinophilic cytoplasm. Still, we have some individual cells, but the keratinization of the cytoplasm is not so much so. Sometimes the cells can be in syncytial aggregates where you can't make out the cell borders. However, that eosinophilic cytoplasm merges with each other and it is dense and eosinophilic. So you need not get confused with adenocarcinoma, the glandular cells. And if you see here, there is a prominent nucleolus and some amount of tumor diathesis is seen in the background. Sometimes some bizarre cells can be seen, binucleate cells with hyperchromatic nucleus and a dense eosinophilic cytoplasm. Whereas if the squamous cell carcinoma is something like that with keratinization, I'm showing you only the surface of the biopsy. And if the cells are like this keratinizing, look at the way it's almost like cytology in the superficial layers here, isn't it? It is very strap like elongated cells. So, how will the cervical smear look like? Very isolated discohesive cells, various shapes. There is dimorphism, and the nuclear characters, the NC ratio doesn't seem to be much increased. However, the nuclear characteristics are present, irregular nuclear membrane, chromatin is there, a small nucleoli is there, and in between you are seeing orangeophilic cytoplasm, cells with orangeophilic cytoplasm showing evidence of keratinization. Once the strap cells start coming and you have change in the shape of the cells, we know there is keratinization. Look at these cells, this similar, this from the biopsy which I am showing, it is the same cells which have come in the center at this rate.
Check.
The nucleus is very hyperchromatic, and these characteristics tells you that you are dealing with a squamous cell carcinoma. You can see three of these cells here which are not keratinized. So looking for other cells will also help you in making a decision. Sometimes you have these syncytial clusters also which helps you in making a decision. Now, what are the problems? What are the cells which can be confused with SCC? Atypical repair. How do you differentiate? We have a cell here which is neoplastic. These are the atypical cells which are enlarged because of the repair activity or a reaction pattern which is occurring here. How do you differentiate? The cells are cohesive. The chromatin is very uniform. Nuclear membrane is regular and there is a small nucleoli. Nucleoli indicates the metabolic activity of the cell, so they can come up in reactive conditions as well as in malignant conditions. But in reactive conditions, the nucleoli usually will be conspicuous. In malignant, it would be macronucleoli. But the cohesive clusters with regular nuclear membrane and uniform chromatin says this is a non-neoplastic lesion. Sometimes, because of the malignancy, the smear which is scraped out could be hemorrhagic and which could be obscuring the neoplastic cells. Then you will have to carefully search the entire smear for atypical cells before calling it as unsatisfactory. Even if you find two or three abnormal cells which are unequivocally abnormal, the smear becomes satisfactory. Coming to the next lesion, that is the squamous lesion, is a high-grade intraepithelial lesion, squamous intraepithelial lesion. Here I put this for you to note that in HSIL, all the cells, there is no maturation. All the cells look like basal or parabasal with increased ratio. So if you scrape it, what you are going to see is only small cells. From the other areas where it's not involved by HSIL, you see mature cells. So when you see neoplastic changes in the cells similar to basal and parabasal cells, it will become high-grade lesion HSIL or SAC. Okay. Here also the cells can come in small groups or individual loosely cohesive clusters depending upon the extent of keratinization, and you have a high increased a high NC ratio and hyperchromasia, and all the nuclear features will be present. That is condensed chromatin or clumped chromatin, nuclear membrane irregularity, but the nucleoli won't be there as compared to the SCC. Now, non-keratinized HSIL. It could come as syncytial cluster like this, hypochromatic nucleus, but look at the arrangement of the nuclei. They're very haphazardly arranged, which distinguishes from the gland.
Sorry for the interruption. Ma'am, sorry for the interruption.
Yeah.
The new students joined through laptop have permission issue, so I request the students to join through laptop. Sorry for the interruption again, ma'am. Please continue, ma'am.
Okay.
Thank you.
Thank you. Now, the problems in HSIL is finding crowded hypochromatic cell groups, crowded hypochromatic cell groups, which because of the nuclear overlap, which obstructs your vision to identify what are the nuclear features. So then you will have to screen the entire smear and see if there are individual cells and whether to label this as HSIL or ASCH. Sometimes the cells can be very small size and get confused with the endometrial stromal cells with the very less amount of cytoplasm, and so hypochromatic it becomes very difficult to identify what we call a small cell HSI. The differentials again. In a postmenopausal lady, this is a atrophic smear. Parabasal and basal cells are there, but this is the same atrophic kind of smear with HSI. So, what is the difference between the two? The cell size is the same, however, the increased NC ratio and the nuclear features are telling that this is a neoplastic change. So, be careful. This parabasal cells come as differentials everywhere. Maybe be it be HSIL, be it be ASCH or ASCUS. So you should be very careful. Nuclear features is the one which tells you that they are neoplastic. Sometimes these cells lose their cytoplasm and they can appear naked hypochromatic like this. You get naked nuclei even in a reserve cell hypoplasia in ladies who have undergone tamoxifen therapy like these small clusters, but they can come in isolated isolated single cell also. But look at the chromatin pattern here. It is very uniform. There is no clumping of chromatin. However, in HSIL, it is hyperchromatic, and rest of the smear will show you the other HSIL cells. Sometimes I've been stressing on hypochromatic nuclei. The nuclei can be hypochromatic. Then the nuclear membrane irregularity. Look at these cells. They have a regular nuclear membrane, hypochromatic nucleus. Are these neoplastic or not is a question. Whether you have to put them as atypical cells, probably ascus, because the cytoplasm is also not there. But rest of the smear in this case was showing typical HSIL cells. So sometimes HSIL cells can have hypochromatic nuclei. Now, next, the lower grade lesions, the low grade squamous intraepithelial neoplasia. The difference here is we are seeing viral cytopathic change, that is the coilocyte formation in the superficial and intermediate cells. So, if you scrape this area, what you are going to get is the superficial and intermediate cells. So, I expect to see in the smear superficial and intermediate cells. The changes will be in these mature cells, and they can occur as single cells or in small clusters, not many cells sitting together, because they're already ready to get exfoliated, so their cell additions are not there, and you see single cells. We have enlarged nuclei, anisonucleosis, but the chromatin is uniform. It might not show clumped chromatin at all in LSIL. It can have uniform chromatin or slightly clumped chromatin. And even the nuclear membrane irregularity is variable. See here, there is a little bit irregularity. There is a irregularity here, but here it is smooth. So the cytoplasmic features are there is a condensation of the cytoplasm and creating a halo around the nucleus, and the condensed cytoplasm is seen here. Okay, the nuclear changes are also seen. So this is a coilocyte. These are coilocytes. However, if nuclear changes are not present, we do not give importance to it. So even if nuclear clear coilocytes are not present, it doesn't rule out a diagnosis of LSIL. LSIL cells can be keratinocytes, orangophilic cytoplasm here. So this was what I was talking about. We have a regular halo around this nucleus. It's not like the coilocyte halo, which is a irregular kind of thing, which is far away. This is because of the condensation of the cytokeratin filaments in the cytoplasm and creating this halo. But nuclear features, the nuclear is regular here and the nuclear features are not seen here. So what we call it pseudocoilocyte. Now, this is a wedge-shaped squamous cell which was floating around in the smear. Is it ascus or LSIL? What do we do in this scenario? We can always say ascus versus LSIL and ask for HPV DNA staining. Sometimes we might not be able to categorize with total confidence. Coming to the AS sketch, here the cells are of metaplastic cell size, increased NC ratio, more than 3 times that of metaplastic cells. They come in small clusters or individual cells, and the number of cells wouldn't be adequate to call it as HSI. The differential here is with the histiocytes. They can look like the HSIL cells, what we saw, but the vesicular chromatin, sometimes grooving of this kidney-shaped nuclei here says they are histiocytes. And the metaplastic cells, as I said earlier, can lead to a diagnosis of HSI as sketch, but the chromatin pattern here is uniform. Coming to ascus, very ambiguous category. Slight increase in the NC ratio again in the intermediate and superficial cells as compared to normal. They could be 2.5 to 3 times. See this fellow? And pseudocoilocyte here with ambiguous nuclear changes. So all this becomes ascus. Here, binucleation, enlarged nucleus, or the same picture, and this is a coilocyte, almost attempt to becoming a coilocytosis. These features and all we label it as ascus. So you could have it as parakeratotic block or a cluster of parakeratotic cells. So what are atypical squamous cells? Now, these are all those ambiguous, equivocal, like it depends on how much can you appreciate, but you still can't rule out a neoplastic cell. You want to alert the clinician, okay, I am suspecting something, but I'm not very confident to call it as neoplastic. Then we put it under atypical squamous cells. But when you have such a category, it is very human tendency to put almost whatever you're not confident into that category. So Bethesda system doesn't want us to do it, so it has put a limit that in your diagnosis statistics, as atypical squamous cell should not exceed 5%. This is a quality metric indicator. This is a quality indicator of your lab performance. Out of these atypical cells, 90% should be ascus, and as sketch should be a rare diagnosis which accounts for less than 10%. And ascus, when you follow it up with biopsy or a repeat cytology or a HPV DNA after complete workup, turns out to be in HSIL in 10 to 20%, or it could be most of them will be NILM. Whereas ASCETCH has a high positive predictive value for high-grade lesions. Therefore, that is where we have to be very careful, because it demands a aggressive follow-up or a workup of the thing. ASCUS can be kept for a follow-up because most of them will turn out to be low-grade lesions or negative. Coming to the glandular lesions, again atypical glandular cells, it is similar to ascus, whereas the changes occur in the glandular cells. Glandular cells, they show cell margin clear cut, but when they go to higher grade lesions, the cell margins won't be visible. So from that we know these are low grade lesions, and we have a regular nucleus, but the nucleocytoplasmic ratio is increased. In all these cells, isolated cells sitting together, cell margins are visible, chromatin is slightly clumped, a little increase in the NC ratio, which is 3 times the intermediate, more than 3 times the intermediate size nucleus. Now, this is one case which I have taken from LBC. This is not conventional, and we can see lot of endocervical cells, lot of clusters of endocervical cells. It's a spellular smear which consists of more of endocervical cells. If you take a closer look, some of these clusters are in rosettes, where the cytoplasmic edges of the apical part of the cells are in towards the lumen, and the nucleus is towards the periphery. Some have come out as strips like that with stratification of the nuclei. We don't have a good orientation, and you can see there is a little ATP of the nucleus. Clusters of cells with stratification of the nuclei, and this cell protruding out, which we call as feathering. Stratification, irregularly arranged nuclei. There is no feathering in this, and this was adenocarcinoma in situ, and the biopsy looked like this. The normal endocervical gland turning into lined by the neoplastic tall columnar epithelium. No invasion is noted. You can see the various cellular changes which we are seeing in the cytology also. Coming to the full-blown adenocarcinoma, cells are hypochromatic. Again, very crowded it is, but this feathering is a good indication. Feathering is the cell, the nucleus lags behind. It doesn't join the cluster. It is protruding out of the cluster, which we call as feathering, which is seen in the glandular lesion. Chromatin could be fine, vesicular. Sometimes most of the times you will have a nucleoli, and the cytoplasm is very wispy, which is because of the vacuolation, mucus content. And this is the tumor diathesis with trapped malignant endocervical cells. This is one case which we had, a little different from what now I showed as endocervical cells. These cells we had, there is a clear cytoplasm, a small nucleoli, a big nucleoli like this, and look like glandular cells. One more cluster, vacuolated cytoplasm, nucleoli, macronucleoli, nuclear membrane irregularity, and wispy cytoplasm, so adenocarcinoma. The same thing with a higher power here. And what was the biopsy showing? Endocervical biopsy, normal endocervical fragment, and with the infiltrating neoplasm, which was in glandular arrangement. If at a closer look, you have these large cells lining these glandular elements with a little bit of hobnailing here and there. I have not put a high power image. So this was a clear cell carcinoma. So adenocarcinoma or the glandular lesions could be of endometrial or endocervical, and sometimes ovarian malignancies also can be detected on pap smears. So what is the impact? Now with understanding the HPV etiopathogenesis in cervical neoplasia, the impact on HPV screening is that we were able to develop vaccines. So primary prevention by vaccine and screening is being impacted by HPV discovery. So it could be vaccinate the young girls, and the primary screening by HPV DNA testing could be done. Whereas HPV, as compared to cytology, HPV DNA testing has a higher sensitivity rate but less specific, because HPV DNA positivity says the virus is there, but whether the neoplastic change has occurred or not is to be seen only by looking at the cell. So cytology becomes a triage, cytology or a colposcopy. The modification in the screening could be, if it is HPV DNA testing, a self-sampling by women can be done, which is taking favor now, because camp organization and all would be difficult. The other thing in the approach, treatment approach, is screen and treat. So if you take all these things, surely cytology load will definitely come down, is what we think, 2040. But this is what is Dr. Ritu and Dr. Wilbur, the editors of Bethesda system, say that PAP test will never go off record because it is a good triage test, cost effective triage test as compared to colposcopy. So the reports of cytology demise have been greatly exaggerated, as said by, modified by Mark Twain. Now, HPV discovery, I said, has led to vaccination, which will prevent the occurrence of HPV infection. Screening could be primary or it could be a triage after cytology, especially with ASCUS and LSIL overlap. Then if it detects high risk HPV, then those people are sent for colposcopy. In primary screening, people having HPV infection are picked up, but women who have neoplastic lesions are not picked up. So we still need a triage either by cytology or a colposcopy. Compared to colposcopy, cytology is much easier. It could be a thin prep, it could be a LBC where we say reflex cytology, or it could be conventional. At our center, we had the opportunity of seeing cytology trials with the conventional smears with HPV positive people. Now the screening which is happening as a primary HPV screening with reflex cytology. So, why is cytology needed? Because HPV infection, not all women which are infected with HPV develop cervical cancer. 90% of the infection in women, infection resolve, it is a transient infection with long latency period. 90% resolve by themselves, and therefore a risk stratification is needed as to which women to follow up and which do not follow up. So this is a cytology triage helps in which women will go for immediate treatment.
Ma'am, we have 5 more minutes for the first session, ma'am.
I have 3 4 slides more. I'll finish.
Okay.
Thank you. Now the recent advances. When you have this, we don't have much experience with it. I have taken it from the literature. When you have some cells where you can't classify whether they are neoplastic or not, we can do a dual staining on pap smears itself, which is done P16 and Ki67. Ki67 captures all the cells which are in cell cycle, which is staining the nuclei as red. Whereas P16 is a surrogate marker for HPV infection, it is a cell cycle marker which stains cytoplasmic. So the chromogen here used is a DAB and here is the AAC, which gives two different colors to the cells. Here, these cells are not in proliferation, therefore, it is not stained with Ki67, but it is HPV infected, so it is staining with P16. So a combination expression of Ki67 and P16 tells us there is a neoplastic process going on in these cells. Now coming to automation in cytology, prior to 2000, we had two scanners which would do that on conventional smears. Because of the various problems, like AutoPAP was not compliant with Y2K. I don't know whether present generation knows what Y2K. Now, switching over to 99 to 2000 was a big thing in information technology. Some of the softwares did not make it to 21st century. One of them is the AutoPAP. Whereas PAPNet made it, but the company went under receivership. So now the imaging systems which are available are the BD Focal's GS imaging system, where it is an image-based analyzer which identifies normal and abnormals. 25% of the normals goes directly to archives, rest are screened by the cytotechnicians, and the normals are redirected for a rescreen by the system, and the abnormals are sent for pathologists for review. Hologic thin prep system is a little different. It sorts out identifies few abnormal cells, draws a histogram, and then mark out the suspicious cells for the cytotechnicians to see it. If the cytotechnician feels it is normal, a report is generated. However, if the cytotechnicians on autoscan identifies, it reduces the 22 FOEs to about 710 FOUs for the pathologist to review, and then a report is generated. However, automated assisted versus manual reading of cervical cytology, the analysis of meta-analysis and a randomized control study says that automated assisted reasoning reading does not increase the specificity for identification of CIN2 plus, which is our target, that is CIN2, 3, or SCC. So it's not required is what is suggested by this famous Maverick trial. Now, with the AI, where are we in cytology scanning? A whole slide is many systems have come up. One or two are FDA approved, which work on the whole slide imaging, but there are complications. It's not as easy as a biopsy slide. Cytology has its own disadvantages for AI to analyze. The whole slide image is cut into patches, and the patch is analyzed by a cell detection model where it studies the individual cells. Plenty of features of nuclear and cytoplasmic features are studied, or a patch-based classification model where it categorizes it into five categories only of the squamous, not of the adenosquamous. And this features, the analysis is fed into a convolutional neural network. This thing we don't know, even the AI engineers don't know what happens here. And then the slide level results with the probability score that it is abnormal is fed into the system. So what is the future? Primary screening is going to be HPV DNA testing. There are 5 FDA approval methods for HPV DNA testing. Most common is the COBAS, and followed by the chlolarity by BT. HPV vaccination is going to come as a primary prevention method. The emergence of self-sampling by HPV testing is going to take a front seat. Then we don't have to organize camps for collection of the samples. The woman can walk in with the sample which she has collected. Obviously, research will go on to discover new biomarkers which could be integrated with AI and have digital health solutions. Thank you. I thank KCIAPM for giving me this opportunity, Dr. Aditya, Dr. Nityashri, and Dr. Ganeshri. Thank you very much.
Thank you, ma'am, for giving us a detailed insight into the conventional pap smear, the foundation of cervical cancer screening. Before we move ahead, due to some technical issues, I couldn't give a proper introduction to Dr. Julian Crasta. Let me take a moment now to introduce her. Dr. Julian Crasta, she is a professor of pathology at the prestigious St. John's Medical College, Bangalore. Dr. Crasta holds an MD, DNV in pathology and also a fellow of Indian College of Pathologists. Her fields of interest include gynecological and placental pathology as well as cytology. She has authored over 65 publications in national and international journals, contributing immensely to the advancement of medical sciences. Dr. Crasta has also led DBT funded research projects in placental pathology, along with several extramural and intramural research projects in gynecological pathology. She has been a mentor, researcher, and leader in her field and continues to inspire through her academic and clinical contributors. Thank you so much, ma'am, for sharing the valuable insights and expertise.
Thank you. Thank you.
Moving ahead, uh, building on the basic conventional cytology, now we'll move to the recent advances, the liquid-based cytology and HPV testing, which have improved accuracy and early detection. To guide us through this, I now invite Dr. Reshma Kini. It is my pleasure to introduce Dr. Reshma Kini, professor in the Department of Pathology at Father Muller Medical College. She currently heads the cytology division and also serves as the quality manager of the hospital laboratory. Dr. Kini completed her MD in pathology from Father Muller Medical College and has pursued advanced training in medical education, including international courses in evidence based medicine, biomedical research, and competency based medical education. She is also a FAIMER Fellow and an active member of International Competency Based Medical Education Collaborators. She has more than 20 publications in reputed journals, has contributed to books, and has presented widely at national conferences. Her academic contributions have earned her several prestigious recognitions, including the David Sackett Memorial Award for Excellence in Research Methodology, Best Paper and Poster Award at national conferences, and multiple prizes for innovation in pathology education. Today, Dr. Reshma Kini will be speaking to us on liquid-based cytology and HPV testing, both of which are modern advances and have significantly enhanced cervical cancer screening. We are delighted to have you here, ma'am. Over to you, ma'am.
Thank you, Ganashri, and I would like to thank KCIAPM for giving me this opportunity. And I would say that I'm honored to be presenting alongside Julian Crasta ma'am, who I know by her reputation and very glad to have seen her today. So yeah, this is a big honor for me. I'll just share my screen and then we'll be off. Is my screen visible?
Yes, ma'am.
All right. So, good morning, almost good afternoon, everyone who's there and patiently listening. So, we'll directly jump into the topic of today. That is, first, I'll be introducing you, taking you through what is LBC. Many of you may not know. Differences between conventional and LBC with respect to collection and preservation of specimen, the technology, morphology, and the efficacy, which is very important for us. What is high-risk human papilloma virus testing and place within cervical screening, cancer screening system. Okay, so LBC was introduced in 1990s to overcome the limitations of the regular pap smear, where people were finding it difficult to look at the cells because of the obscuring factors like inflammation and blood. So after in 1996 and 1999, FDA approved two very famous LBC testing systems. One is the ThinPrep from Hologic and one is SurePath from BD. So these two are actually internationally validated systems. There are many locally available systems also, but they have not yet been so thoroughly validated as to for me to mention them here. But they can be validated, and if enough scientific evidence is there, maybe they will take over the other two systems. So what are the differences between conventional PAP and LBC? So conventional PAP I'll be referred in this slide deck as CP, and liquid-based cytology as LBC. Okay, so specimen collection, already ma'am has told that in case of conventional PAP, the smear is directly done onto the slide, and this slide may either be fixed immediately or it can be fixed in alcohol, or it can be fixed using a spray fixative. In liquid-based cytology, the specimen is collected using a brush and the specimen is directly deposited into a liquid. And there are two things that happen. In SurePath, the brush is washed into this liquid and then the brush is broken. Not broken, there's a joint and it is disjointed and the brush is left into the solution. Whereas in case of ThinPrep, this brush is swirled 10 times into the liquid and it is discarded. So this liquid is what is we receive in our lab. So in fixation, yes. So the other difference between, I'm very sorry about this. Yes. So the differences between, there's a difference in the collection and how the sample is collected. So in conventional PAP, the fixation happens almost immediately, but like ma'am said, depending upon the temperature, humidity, and the delay, there might be some delay in fixation, whereas in liquid-based cytology, because the brush is directly inserted into the liquid, the delay is not there, immediate fixation happens. Now, how this is important for us is that because of the fixation happening immediately, the cell size will be doesn't increase. So we will have to get used to the new cell size when we switch over from conventional to LBC, if that is what we are planning to do. So cell size might be smaller. So that is something we have to get used to. The second advantage we can say of LBC is that the liquid that is there, that is sent to the lab, only some portion of it is utilized to make a smear. So liquid remains, and that can be used for ancillary testing. And the third important point is, if you are fixing the cytology regular conventional pap smear using carbovax, if it is preserved properly, that if it's air dried and it is packed properly, the morphology will remain indefinitely preserved. This is the exact term used in the literature, indefinite. Whereas in case of LBC, the preservation of the samples happens to up to 2 to 4 weeks if left outside the fridge, and up to 3 to 6 months if it is kept within the fridge. So this is the difference between the collection and preservation of the conventional and thin prep. So what is the difference in the technology? Of course, in case of this is LBC of thin prep. There are the technology between thin prep and sure path are two different things. So in thin prep, what happens is the cells are there floating like this, and there is a negative pressure applied into this liquid, and there is a membrane filter against which the cells attach themselves. And this membrane filter has a sensor which checks the pressure gradient, and once the pressure gradient is reaches to a certain level, which informs the equipment that 5,000 of around 50,000 cells are there on to the filter. The filter inverts itself and presses it onto a slide, and then the slide is taken out and it has to be stained. In sure path, what happens is that this is the other method. The liquid is first vortexed and the cell adhesions are broken. After that, it is layered over by a density gradient reagent. Okay, this is a sample and there is a density gradient reagent. After that, centrifugation happens, and then a cell pellet is formed. In that cell pellet, most of the blood and mucus has been removed, and this cell pellet is resuspended and gravity is used to prepare the slide. So this is the difference in the technology. So in thin prep, it is a methanol based fixative, whereas in sure path it is a ethanol based fixative. The cell capture method is filtration method. Yes, the difference here is why for us this is important. In sure path, in thin prep, the monolayer cell diameter is 20 mm and it has about 50,000 cells. Whereas in sure path, the area of the smear is around 13 millimeter, but with the same number of cells. Now, how that makes difference for us is, if you look at the slide here, in sure path, the cells are, there is more overlay of cells as compared to thin prep, because this is a smaller smear with the same number of cells as thin prep, which is a larger smear. Okay, this is also important when we are calculating or when we are estimating the adequacy of LBC slides according to Bethesda system. So this is something to keep in mind. Yeah, so then coming on to morphology. So what we discussed till now is, how is the sample collected? The sample is collected directly onto the smear in conventional, whereas it's directly collected onto the fluid. And then the fluid is processed either by filtration or centrifugation technique. Two different sizes of smears will come out if based on which machine you are using. One is 13 mm, one is 20 mm. Okay, both of the slides will contain around 50,000 to 60,000 cells. Literature says that thin prep generally has a less number of cells than sure path. Slightly less, not enough to be statistically significant, but less. So in Bethesda system, for LBC, around 5,000 cells are considered as adequate. If you look at the Bethesda recent third edition, it tells you that depending upon the diameter, okay, this is for sure path 13 and this is for thin prep. Depending upon the diameter, this is the area you're scanning, and this is the number of fields you should be looking at in 10x and in case of 40x. So how many cells will be there and how many fields you have to see, it will depend upon whether you are using thin prep or sure path, and also it depends upon what is the diameter of your microscope. So we use a microscope with a field number 20, so we can scan it at 10x or at 40x. So and we are using thin prep. Okay, so for me, in my 10x, I will be seeing around 100 cells. That means I will have to scan 50 fields to ensure that there is adequate specimen. Or if I am looking at 40x, in 40x, I will be seeing around 1,600 cells, which means 3 fields I will have to scan. So this is why you should know what is the difference and which system you are using. And if you are using a homegrown system, there are some homegrown LBC system, or if you are using cytocentrifuge technique, which some people are doing, you will have to establish your own criteria, how to go about it and get that criteria validated. So I will not be going into the details of how the morphology looks because ma'am has already dealt with it. What I'm going to do is only going to show you the difference between what conventional PAP would have shown and what an LBC shows in terms of morphology. So this is how an LBC slide classically looks. It will have a monolayer of cells. The background will be clear. Almost always it will be clear, except if a lot of inflammation is there, we can see some RBCs. Of course, we will see inflammatory cells will be there, but not as dense as we see in conventional, and overlapping usually will not be there. It can be there sometimes, but usually it will not be there. And even if it is there, there are ways to get rid of this overlapping, so you get a monolayer cell. So in this field, you can clearly make out there's a superficial cell, intermediate cells, and in the center we have the endocervical cells. So this is how clear it looks. Okay, so next moving on to when it comes to the infections, as per my personal experience, there is no difference in the way it looks, except that Candida, the shish kebab appearance, is a little more common than in case of conventional smears. Otherwise, infections, reparative change also do not look very different in LBC as compared to conventional. So directly in ascus, what happens in ascus is that because the background is more clear, the blood is not there and inflammation is not there, the incidence of picking up ascus in LBC is slightly more than in case of conventional. This is based, what I'm talking is based on literature references. Okay, so in case of ascus in LBC, the cells usually will be more dispersed and more monolayered, and the nuclear changes will be better appreciated. Initially, when we switched over from conventional to LBC, we used to identify almost every cell as abnormal. Because fortunately we have a backup of HPV testing, we did test a few cells and a few cases, and then we realized that not everything that we were identifying as ascus was actually positive for HPV DNA. In the literature, around 50% of the ascus, if you send for HPV DNA testing, which we call as reflex testing, will come positive. But in case in our case, we got only 33% positive. That means we were definitely overestimating our ascus category, and so we had to retrain ourselves to how actually it looks different. Okay, so in case of L cell, the perinuclear halo that we are supposed to see becomes very crisp in case of LBC as compared to the conventional PAP. So it is little easier to pick up in conventional in LBC. That is the only difference. Otherwise, there is no morphologically, there is no much difference. In case of H cell, what happens is dispersed abnormal single cells are seen more commonly than in case of conventional PAP, and fewer abnormal cells may be present because we are seeing only fewer cells as compared to conventional. In conventional, in our hospital, we get 2 slides and there's abundance of material, and you will not miss it even if you know happen to for a fraction of second lose concentration, you'll definitely pick it up somewhere else. In LBC, that opportunity is not there. Your concentration has to be 100% onto the slide at all times, because the cells might be lesser in number, because it tends to mix the sample and give you only a representation. So that happens, and cells can be quite small and you can mistake them for histiocytes, just like ma'am said. And nuclei may be normochromatic or even hypochromatic. The same thing was also told by ma'am, that in LBC we can have this issue. So in case of squamous cell carcinoma, one of the important things and very well noted feature is that the tumor diathesis, which we are happy to note in conventional PAP, is found only very less in case of LBC. It might be just surrounding the cell groups here and there, and this kind of diathesis, that is an admixture of inflammatory cells, blood, and the cell debris, okay, that is called tumor diathesis. It will not be there uniformly in the background, it will be stuck on to the cell groups, and this is called as clinging diathesis. So this is the difference between LBC and conventional. In atypical endocervical cells, groups are more rounded and three-dimensional. Okay, this is one common feature in all the glandular cells in LBC, that they all become suddenly three-dimensional, and in the center it becomes very dark for us to see what the nuclei looks like. So looking at the periphery of the nuclei, or in case there is a chance that some of the cells have shed out, and looking at nuclei of that becomes very important for us. So the same problem is encountered in atypical endocervical cells, favor neoplastic or adenocarcinoma in situ also. In adenocarcinoma in situ, apart from the feathering that ma'am was telling, the stratification, nuclear stratification, the nuclear irregularity, as well as the nuclear increase in the nuclear size, we get something called as bird tail-like arrangement. This is the bird tail-like arrangement that we can see in adenocarcinoma in situ in case of LBC. Yes, this is the same thing in adenocarcinoma, endocervical as well as endometrial. I am talking, it's not that they look the same. I'm just telling what is the commonality between them is that you will get three-dimensional group with center being very dark and the periphery being little difficult to appreciate what the changes are like. But otherwise, all the criteria that you are using to diagnose the any lesions using Bethesda for conventional, the same criteria is to be used. I am only telling you what are the differences. Okay, now who is better? This is the most challenging questions for everybody. Is conventional PAP better or is LBC better? So which one should we opt for? So LBC definitely yields cleaner smears. Theoretically, it should help in better detection of the lesion. The distinct advantage of LBC is conclusively proven only in identifying ascus and CIN1 lesions. Okay, so only confined to that LBC can pick up more ascus and LBC lesions. Ascus and CIN1 lesions. So what happens when it comes to CIN2? So this is something I have put together by looking at a lot of meta-analysis and Cochrane reviews. Okay, and what I have found and is that when it comes to sensitivity for detection of CIN2, LBC and conventional are very similar. Specificity is same or slightly lower when in relation to conventional pap smear. HCl and AGC detection, some series suggest higher glandular detection. This is definitely there, that some of the series are saying that the glandular lesions are picked up better in LBC, but not so much as to make a gargantuan difference. So unsatisfactory rate definitely is much lower. The thing with LBC is if you do get an unsatisfactory smear, you have to judge whether actually the specimen has low cellularity or is it that your slide has low cellularity because there was a lot of mucus in the specimen. So what you can do is they do a procedure called reprocessing where acetic acid is put and it helps in breaking down the mucus and the RBCs, and there is another proprietary solution which helps in breaking down the mucus and you can get a new slide done. And in 50 to 60% of the cells, the newer slide, reprocessed slide, has more material and has adequate material as compared to the first one. So this is one advantage of LBC. Definitely there are lower number of unsatisfactory smears. And of course, because there is residual sample left, you can definitely send it for HPV DNA testing and also sexually transmitted infection testing if you have the molecular thing for that. And liquid-based cytology is faster. Screening time is very much reduced. I did not find any literature to say how much it was reduced, but by personal experience, I can say that at least it saves half amount of time as compared to conventional smear, especially if you're seeing two conventional smears. One single LBC will save you more than half amount of time. So that is a definite advantage. So when you compare conventional and LBC for the purpose of cancer screening, it actually makes no difference, no much difference, except that LBC might have a little more advantage when it comes to glandular lesions. And of course, the time is saved and less amount of inadequate smears. But otherwise, it doesn't make much of a difference. So what are the advantages of LBC? Standardization of processing. Okay, so you can always say when you write your papers that what method was used, you can just quote, we use thin prep, and then you're done. So you don't have to worry about it. Minimal air drying artifact, compatible with automated screening devices. Now, apart from what ma'am was saying, we are also having AI. So for AI, it is easier to, I believe, train on a molar layered smear than on a conventional, though AI should be able to do both, but it is easier. Allows for batch processing. Residual sample can be used for additional testing, uniform distribution of cells in a monolayer with less overlap, reduction in inflammation or blood in background, lower rate of unsatisfactory samples, and less screening time. So these are the advantages. Nowhere I am mentioning that it is better than conventional PAP. Okay, there are advantages, but it is not better than conventional PAP. Disadvantages is the cost. This is humongous. The LBC machines, both ThinPrep and SurePath, the cost of the machines can range from 80 lakhs to 1.2 crores. Apart from that, each of the kit costs around, depends upon which kit you are using, can cost from 400 to 800 each kit. That is, apart from the machine you have to also invest in the kit. So all this cost, if it has to be borne by the patient, then the patient will have to pay around 800 is the minimum they will have to pay, to around 2000 to get an LBC done, whereas a pap smear can be done at around 100 to 200 cost to the lab, and when it translates to the patient it might come around 300. This is I'm talking about when we are charging the patient, not when the government is doing mass screening. So the other disadvantage is that training in sample collection, processing and reporting, and loss of background material in case of tumor diathesis. If you are not aware of something called clinging diathesis, okay, that can be very faint, you may miss out on that one important element. And of course, the 3D balls that happen in case of all glandular lesions can also be a disadvantage. Yeah. So as per WHO, we should start screening. Yes, we are going to talk about little bit about screening for cervical cancer, because this is very important. We cannot sit alone in our lab and say we are going to look at pap smears and not know anything about what's going on. So we start screening at the age of 30 years according to WHO. And we can stop screening at 50 if 2 consecutive screening tests are negative. So target age group for screening is 30 to 49 years. This has been reduced to 25 years in India if cytology is available. I will show you the recommendations. So what are the different methods of screening? We need to know a little bit about this. Organizers, I just need your permission. I might take another 15 minutes if that is okay.
Yes, ma'am. Sure, ma'am.
Yeah, thank you so much. Yes, so the methods of screening, we should know this. The methods of screening cervical cancers are 4 major ones. Visual inspection with acetic acid. This has nothing to do with cytology. Visual inspection with Lugol's iodine. Cytology, this is our conventional PAP and LBC, and testing for high-risk human papilloma virus. So basically, there are 4 methods for screening of cervical cancer. So visual inspection, why this all I am telling is because it will come later. So visual inspection with acetic acid is also called as VIA. In this, what happens is that there are abnormal proteins within precancerous cells in the cervical, in the ectocervix or endocervix. So when acetic acid is applied, it coagulates these proteins and the abnormal area appear aceto-white. Okay, so this is positive VIA. So once this patient undergoes this and it is positive, she is directly taken up for treatment in a single sitting. So she just comes for screening, acetoacetic acid is applied. If there is aceto-white, then she is directly taken up for treatment. We do not know which lesion she has. Okay, we do not know whether it's L cell, whether it's H cell. Okay, we don't know that. Of course, it's not a CA, because the CA, it would be very obvious that there is a lesion there. So she's directly taken for treatment. So this is a very appealing method in places where compliance is not expected. That is, if you tell the patient, okay, come again after 1 year and get a pap smear done, and you are very certain that the patient will not come back, which is very likely to happen in our country, then to hold the patient on and treat her then and there in one sitting is a very appealing kind of screening test. Okay, the next one is visual inspection with Lugol iodine. This similar to applying acetic acid, Lugol's iodine is also applied. Only thing is, in precancerous lesions and cancer contain, there is no glycogen. Okay, whereas the rest of the cells will contain glycogen. So these areas will take up yellow color. So VILI, this is called as visual inspection with Lugol iodine. It has a little less sensitivity and specificity than the previous one, that is VIA. Next is HPV, detection of high risk human papilloma virus. Now, I think all the PGs do know that cancer cervix is caused by human papilloma virus. So identifying the virus is one of the very much appealing method of screening for precancerous lesion of the cervix, or just prevention of carcinoma cervix, not identifying precancerous, just prevention of carcinoma cervix. So primary screening test that is suggested by WHO is HPV DNA testing. Now, apart from testing its DNA, what all can be done? Okay, you can test for HPV mRNA, you can do a genotyping, you can do a immunocytochemistry that ma'am was showing just now, P16 and Ki67, you can do that. Or still in research is ISH, that is in situ hybridization, next generation sequencing, and serology. These are still in research, but HPV mRNA tests are already available, genotyping is already available, and dual immunostaining, obviously, you have already seen, and it is already available. Now, what does WHO recommend? Okay, there might be numerous methods of detecting HPV, but WHO recommends that you use NAT, that is nucleic acid amplification tests. Okay, in nucleic acid amplification test or NATs, there are two types which we should know about. One is called target amplification. Target amplification means we take the DNA and we amplify the DNA using PCR, and then we identify whether that particular DNA is there or no. That is target amplification. The second type of amplification is signal amplification. We are not increasing the quantity of the DNA, we are not duplicating that, but we are enhancing the signaling whether it is there or not. Okay, not required to go in detail, but this much you should know. Nucleic acid amplification test is of two types. One is PCR based, where we are enhancing the amount of quantity of DNA and then looking for whether it is present. The second type is we are enhancing the signal only. The DNA quantity we are not enhancing, only the signal we are amplifying and trying to identify if HPV DNA is there or not. Now, WHO, now what happens? Okay, even in HPV testing, there are different machines which do different things. So there are some machines which can identify HPV 16 and 18 and then pulls the rest off as other high risk HPV types. Okay, so this is important because in the if HPV 16 and 18 come positive in a woman, she is directly taken up for colposcopy. Okay, because it is really high risk. Whereas if she has other high risk types, then she will be watched maybe for 1 more year, because like we already know, most of the HPV are transient infection, they may go off. So if it turns out that HPV 16 or 18 is there, she will be taken up for a little higher, she will be followed up with colposcopy. If it is other types, she will not be, she will be followed up but not with colposcopy, and she'll be asked to return and come back after 1 year. Okay. All right. So now these are some of the companies providing HPV DNA testing. So if you look at the methodology, okay, if you look at the methodology, that is the third column. So some of them are signal amplification. Okay, of course, the way they are amplifying the signal, this is chemiluminescence based, and this is RNA probe and hybridization and other things. These are PCR based. Okay, so what we are having in our lab is this one. We have cartridge based real time PCR. So you have to know this, and the next important thing is you should know this also. So pool detection of 14 high risk types means it is not telling you whether 16 and 18 is there separately. Contrast this to the last one, which is telling you reports HPV 16 separately, 1845 as a group, and pooled others. Okay, so there are some ones which can see. If you look at COBA's 4800, HPV 16 and 18 are reported independently, and rest of the high risk types are pooled. 12 high risk types are identified, but they are pooled. So depending upon what how your system is reporting, okay, whether it is giving you just that HPV high risk HPV type positive, or it is telling you HPV 16 positive, or apart from HPV 16 something else is positive, or it is telling you HPV 16 is positive, HPV 18 is positive, and all the other high risk types are pooled. Okay, so because this will depend upon what you will tell the gynecologist, okay, how the gynecologist will take forward the patient. That is very important. Okay, so WHO now recommends HPV DNA testing for primary screening for carcinoma cervix prevention. And this is because there is now an advent of self-sampling, where the women can sample their cervix at home itself, cervicovaginal region at home itself, and send in the samples, and that can be tested. So this does not require camps. This does not require a gynecologist. Okay, it avoids a lot of things. It actually doesn't require a pathologist also. So it directly goes for HPV DNA testing. And the reason possibly is that, okay, 1 second. Yeah. So if you look at this, this is a meta-analysis done. So if you look at the comparative sensitivity, specificity, and diagnostic ratio of the various tests that I just mentioned, if you look at primary HPV testing, the sensitivity is quite high, around 80%. Primary HPV, the specificity is okay. and diagnostic odds ratio is 10%, and this has the best area under the curve. But cost of this test is will be around 1,400 to 2,000. Okay. The next one is pap smear. If you look at it, the sensitivity is a little low. That means we might miss out on 40% of the women, okay, uh, who have who are having a CIN2 proven CIN2. Okay, 40% we might miss out, but we can be certain that those we identify will definitely be harboring HPV. That is 97% specificity. Okay, and the cost of it is around 300 to 800. If we look at both and look at the cost, okay, and then the next best would be actually the VIA, the visual inspection with acetic acid, which has moderately good sensitivity and moderately good specificity. And very important thing is the cost is around 50 to 100. So when you put all of these together, the ICMR, or in India, the ICMR, which is released its protocol, has actually no place for cytology in its document at all. It just says do VIA, because according to because we do not have a systematic collection of sample from the periphery, we have to the cytologists are available only in urban centers, so that will not be enough to do a mass screening. That is why ICMR does not recommend cytology at all. It directly recommends only VIA as primary screening methods. Okay, so of course that does not mean we don't have a place. We do have a place, like ma'am said, because we have two management approaches. Yeah, I think we have done this. Huh. So role of cytology in WHO framework. So in the ICMR, there's no place for cytology. Let us look at what WHO say. Cytology may still be used as a triage option if it is already a part of existing quality assured program with sufficient trained workforce. So if we already have a cytology lab, then we can definitely use it as a triage. So if HPV comes positive, do we directly treat her even if it is 16 and 18? No, we need not treat her if you have a cytology lab. If you don't have a cytology lab, yes, she'll directly go for colposcopy. But if you do have a cytology lab, you will look at the pap smears and you will decide whether she has HCIL or LCIL, or she has no abnormality at all, which is very much possible. If she has no abnormality, then the patient will be asked to come back again after a year for repeat testing. She will not be subjected to colposcopy. So in that way, cytology still has a place in WHO framework. Okay, so what happens when we give our reports is very important.
Ma'am, excuse me,
Yes.
ma'am. Last 5 minutes for the session, ma'am.
Okay. All
Is
right.
that okay, ma'am?
So what we will do is, yeah, I'll finish in 5 minutes, no problem.
Yes,
So there
thank
are
you.
two approaches to management. This you should know, because you should know when you have given ASCUS or LCIL or HCIL or whatever it is, what is going to be done to the patient. So there are two approaches. One is screen and treat the patient. Okay, this was for visual inspection with acetic acid, where you screen the patient and treat the patient immediately. Even in HPV testing, same thing can be done. She comes HPV positive, you treat her, okay, without doing any other steps in between. What you can also do is screen, triage, and treat. Okay, so HPV DNA comes positive, you do a cytology, that is a triage, and then treat only if it is CIN2, CIN1 or 2 or above. Okay, if CIN1 or ASCUS is there, you still withhold colposcopy. You tell her to come back after 1 year, but CIN2 or above, send her for colposcopy and biopsy. That is triage. Okay, I'll just show you what it means. Probably it will make more sense. All right. So this is the FOGSI recommendation. FOGSI is Federation of Obstetric and Gynecologists in India. So this was put forward in 2020, 2018, I believe. So this is what they are saying. So this is first they are recommending, if you are doing HPV testing, you do HPV testing. If it comes negative, she returns to screening only after 5 years. If you are using cytology, she will return if negative only after 3 years. Okay, so in HPV DNA testing, if you're doing 5 years, she'll come back. If you are doing cytology, she'll come back after 3 years if no abnormality is there. If HPV is positive, okay, and you didn't have a cytologist, then the patient would directly go for colposcopy and biopsy. But if you have a method to triage, okay, that is using cytology, and if it is only more than ASCUS, okay, if it is NILM, repeat HPV test at 1 year. So this is where you're doing a lot of saving for the patient. Saving means saving in terms of discomfort, not money. So repeat HPV test after 1 year. But if she is ASCUS or above, she's sent for colposcopy and biopsy. Actually, the recommendation is if she is having CIN or above, but here they have recommended if ASCUS or above, then she goes for colposcopy and biopsy. So this is the meaning of HPV testing. This is screen and treat if she were to go directly, or screen, triage and treat. Okay, anything above CIN2 will directly go for colposcopy and biopsy. So you should know that. So if you are doing cytology and you have seen ASCUS, if you have HPV DNA testing, get the patient tested for HPV DNA. If she is negative for HPV DNA, ask her to come back after 1 year. 6 months, 6 to 12 months, they say, ask her to come back after 1 year and get an HPV DNA test repeated. If she comes positive for HPV DNA, that means she is HPV positive, cytology, ASCUS positive, directly send her for colposcopy and biopsy. So having a cytology even in when HPV is there makes a lot of sense, because why do you want to subject a patient to colposcopy when it is not really required? Okay, and there were a lot other things that we could have discussed, but that's okay. We are up with the time. So I would just like to say that in summary, choice of cervical cancer screening method depends on many factors. You saw that now, the cost of it, the sensitivity, the specificity. Is there an availability of quality good cytology program in your institute or not? What is the availability of HPV DNA test or not? So you have to put a lot of factors into place and arrive at something for your institute and the place of work. So it is not to be done just because something is available or something is not available. Then choosing a method or protocol depend upon what best works for you. Both conventional and LBC have their own advantages and disadvantages. Okay, that also you should know. And aim of bringing down incidence of cervical cancer cervix is regular screening by any method. So if you are posted in DRP, please don't tell the patient that oh, cytology is not available here, we can't do anything. See if you can get VIA, because any method of screening is far better than having no screening at all. And there is no alternative for you. Whether cytology will be there or not there in the next 5 years, definitely in this exam for you it will be there. So you have no option except to see the slides. The more number of slides you see, the better for you. All right, so there is no escaping that. So yes, with that I would like to acknowledge team Hologic. We have ThinPrep 2000. So I would like to thank them for some of the slides that they have provided and continued support that they are giving us. I would like to thank KCIAPM for giving me this opportunity, and my team and all of my PGs are hopefully still sitting and watching this in one single room. So yeah, thank you for them. And yeah, and last but not the least, we are hosting the Indian Academy of Cytology Karnataka chapter uh, conference, annual conference, the ninth annual conference on October 27th and 28th. And all of you are welcome. Postgraduates, there is poster presentation, paper presentation, and of course, there is post of academic speakers coming up. It's a 1.5 day conference and half-day workshop. So please do come. This is a beach city. By then it will stop raining, hopefully. So you can really enjoy. This is on Monday and Tuesday. And we have been circulating the link. And tomorrow is the last date for early bird registration. So please do register. And looking forward to meeting you if you do come. And yes, I suppose that's it. Hope you learned something.
Yes, ma'am. Thank you, ma'am, for the thorough and enlightening session on liquid-based cytology and HPV testing, and also for sharing your personal experience on the use of both conventional PAP and LBC for diagnosis in different conditions. Now, with that, we'll move on to the vote of thanks. I take this opportunity. Ma'am, can you please stop sharing this? Yeah, thank you, ma'am. Now, I would like to move on to the vote of thanks. I like this opportunity to extend my heartfelt gratitude to our esteemed speakers. In behalf of the Residents Committee of KCIAPM, thank you, Dr. Julian Crasta, ma'am, and Dr. Reshma Kini, ma'am, for your excellent talks, taking us through the basics of conventional pap smear and to the latest updates in liquid based cytology and HPV testing. Your insights have truly broadened and also highlighted the latest advances available to us in the field of cervical cancer screening. I also sincerely thank KCIAPM, Dr. Aditya Agnihotri sir and Dr. Nityashri ma'am for giving me this wonderful opportunity to moderate today's session. Also, thank you, Aditya sir, for always standing as a backbone in handling technical glitches. And of course, a big thank you to all the patient viewers for staying with us. So, this was Dr. Ganeshri, KCIAPM Residence Member, moderating today's session. With that, we formally conclude today's program. Thank you all once again.
Have a nice day, everyone.
Thank you.
Thank you, ma'am.